Hello, my name is Daniel Rosen. I am a endourologist at Westchester Medical Center. It's a pleasure to speak with you about the metabolic workup and treatment of kidney stones. I'm going to be discussing things that are both what I would phrase as empiric or well accepted within the community, as well as things that are my personal practice, and I will do my best to highlight the difference between the two in order to make this as useful as possible for the in-service and the boards, and that this will be a useful review. So first thing to mention is that stones are common. Whether you're going into endourology and kidney stones, or you're going into robotics or female urology or whatever it may be, you will end up seeing stones in your practice. This is, steadily the rising rate of stone incidence or stone prevalence over time. As people get older, they tend to have more kidney stones, and you can see that just as a matter of as time has gone on, more and more people have been diagnosed with kidney stones. And the very good news is, while metabolic stones may seem somewhat complicated, especially if you're not doing it on a day-to-day basis, overall, most of the time, if you follow some pretty basic principles, you'll be able to determine the treatment. Most of the time, you're dealing with either, one of two types of stone, calcium or non-calcium stones, is to generally break them up. Really, on a practical basis, dealing with just two drugs. There are a couple of zebras. These will certainly show up in your in-service, and some cases are difficult and sometimes require a little bit more trial and error, or a little bit tougher. First, how to read a 24-hour urine. This happens to be, you can either usually get them from either LabCorp or Quest, or there are a few other companies, but those are the two main ones. What I do to initially read it is, the first thing that you want to check is your total urine volume. If this is something like 200 milliliters, the patient probably did not collect a full 24-hour urine. The other thing to ensure that it's true is you want to check your creatinine. They should be producing, this is total creatinine, as opposed to a measurement. You want to make sure that there is enough here that this is a true urine collection. The second thing, after doing those things, is you want to be looking at your citric acid, because hypercitraturia is one of the most common issues, and that can usually be solved just with potassium citrate supplementation, whether that is a medical that you give them or if they do dietary, that you can do. The other important thing to realize is, when you're reading this 24-hour urine, to understand it within the context of the type of stone that patient has. Because if you know what stone they have, you know what you're looking for in the 24-hour urine, and whether any of these abnormalities will actually matter or be relevant to that patient. Because if you think about it, we're doing 24 tests here, and the chances that someone has at least one of those being abnormal is very high. The question is that abnormality actually related to the stone they have? Do they have a hyperoxaluria, but they're actually producing uric acid stones? Does that actually make a difference? And that's the important context with which to read it, and honestly, the most important context with which to understand all of the things that we're going to be talking about today is, what kind of stone is this patient actually producing, and therefore do these abnormalities make a difference, or do they make sense to target? So we'll look at these other types of things that also can play a role, things like the sodium, the magnesium. These are really, these metabolic and environmental are really the main things. I think in overall, a big deal is made of relative supersaturation, because it makes a difference in terms of the stone the patient's actually producing. But if you have an analysis and you know the stone they're truly producing, that's really what's going to drive it, more so than in any number that you'll hear in the supersaturation. So this is really two talks. This is a talk on calcium stones and a talk on non-calcium stones. And I hope that you notice that I start with the type of stone as opposed to the metabolic abnormality, because that's a much more efficient way to understand what's going on here. So calcium stones, you can form calcium stones for any number of reasons, and we'll break them down here. In general, I like to break them down in patients who have a normal amount of calcium, but for some reason that we'll talk about in a second, they're forming stones, or they have too much calcium in their urine, and that's why they're forming stones. The three reasons with a normal amount of calcium that you could be forming too many calcium stones is there could be a nidus there, and that shows up most commonly in Hyperuricosuria, and certainly shows up in the boards that way, even though it's not super common in the real world. That you don't have an inhibitor, like that you have Hypocitraturia, or that there's too much of a substrate for it to bind with Hyperoxaluria. Ironically, you'll find Hypocitraturia is the real world reason most of the time for someone to be forming calcium stones, but on the boards that doesn't really show up, and these two other reasons really do because they're highly testable. So calcium stones made simple. If you have calcium and a substrate, in this case it's going to be calcium oxalate, you're going to form that calcium substrate or calcium oxalate. If you have calcium binding with not that, it's not going to form that calcium oxalate. And we basically treat all calcium stones, or many calcium stones, by giving it citrate to bind with instead, which will pass out through the urine without forming a stone. It is worth noting the concept of supersaturation. It's the ability of molecules to remain dissolved in a solution despite being beyond their usual precipitation point. And what I like to think about is that at all times, basically, you could be forming kidney stones were it not for natural barriers that your body has to prevent that. And that is that your body has inhibitors. The most common is citrate, and there's a thermodynamic barrier to precipitation. But if there was a nidus there that would promote that precipitation, that can be overcome. So you're basically in your urine, you're always ready for there to be a precipitate. It's always ready to go, and we have things that are stopping that from happening. And if we don't have those inhibitors, then we're going to end up forming kidney stones. And so that inhibitor, that Hypocitraturia, sorry, that citrate, when that's missing, that can be a big cause of kidney stones. So if you have Hyperuricosuria, if you have too much uric acid going on, it's not that you end up forming uric acid stones, but that nidus is there to be causing calcium stones. And I cannot stress how much this comes up on the boards in the in-service, them asking this question. So having too much uric acid will end up causing calcium stones. It's the nidus. So if the nidus is the problem, you can get rid of the nidus, and that's with the allopurinol, and that's where that'll come up. Now, what's a little bit difficult is these are calcium stones, so empiric treatment with potassium citrate will still work. And honestly, your general suggestions of limiting the salt and animal proteins are still going to be effective in these patients. And many people will treat patients who have even a isolated hyperuricosuria with potassium citrate or some form of citrate supplementation before they'll use allopurinol. I've actually seen questions on the in-service asking it both ways, which can be a little bit difficult choosing which ones to choose. And honestly has to do with who wrote the question for what that answer is going to be. But if you have someone with written a completely normal, or they give you a very high citrate and hyperuricosuria is the only thing that's happening, and they're forming calcium oxalate stones, that's when you're going to have allopurinol be your answer over potassium citrate. So the second option is that you don't have enough of the inhibitor, and that's pretty common. You can see that in metabolic acidosis patients with the distal RTA, where you will just have an isolated low citrate. And it's very simple. You give them more citrate. You can do that dietarily. You can give them lemon water. Patients love that. It's actually very good for, I would say, long-term compliance. They're willing to do it. I tell them to get a bunch of lemons, which keep pretty well in the fridge. Put a lemon in every day, and that does pretty well. Or you can give them a metabolic supplement, meaning potassium citrate or sodium bicarb. Sodium bicarb is basically baking soda. This can actually be pretty tough. There are GI side effects. These are very large pills. Patients with IBD, you'll see that showing up on your in-service. You need to sometimes give a liquid formulation because of the quick transit time, and it doesn't get absorbed. I check a BMP pretty regularly, especially on elderly patients, to make sure that we're not overloading them with potassium. And there's a waxy coating on the pills, which the patients will sometimes see in their stool. Tell them about that ahead of time. that will save them a lot of anxiety as to what's happening with their stool. It also, when you have that waxy coating, this is on their in-service. This star will usually show this has been an in-service question in the past. You will see that waxy coating in the stool, but the medicine itself has come out, and so you can just reassure the patients they don't need to change the medication. This is my own personal soapbox, which is that, taking potassium citrate is a big deal. You're giving this patient basically this medicine for life. And the conversation with that patient should reflect that. You shouldn't, just be like, oh, here it is, go, you're fine. If you going back to one of the seminal papers in this field of the actual potassium citrate trial, where they gave all this potassium citrate, you actually had non-compliance in that trial of patients overall. If they were supposed to be taking 12 pills, they only took on average 8 pills a day. So you really do see issues with that, and that's something to consider in conversations to have with your patients. So finally, you can have too much of a substrate, hyperoxaluria. So first of all, there's primary hyperoxaluria that you'll obviously see earlier in life. Thankfully, lumasiran has recently been approved for that. It's a subcutaneous injection, and it decreases the endogenous liver production of oxalate. You will see this on the in-service all the time with patients with bowel disease or dietary intake, meaning excessive vitamin C. Patients with decreased calcium intake will have hyperoxaluria, and that actually showed up in one of the dietary trials, as well as excessive black tea and dark chocolate. You really won't see that. Ironically, this is pretty rare. It's 8% of cases, but if you go online, right, this is 95% of diets. And the joke I like to say is it's a slam dunk in-service question because you recognize it and you'll quickly be able to answer it, right? If they're supplementing really high with vitamin C, they're having a ton of vitamin C, that patient has hyperoxaluria. So how does it get into your body? Well, it's actually, a ton of is absorbed dietarily. And most of it actually passes out into your stool. The thing is, when you do absorb 25 milligrams a day, that really just ends up being excreted into your urine. You also have a natural of this vitamin C being endogenously produced into your urinary oxalate. And the combination of these two will lead to overall a high urine oxalate. So if you have too much endogenous production, or you have too much dietarily, you can quickly get hyperoxaluria. That's also why the low oxalate diets are not completely effective, because you have this natural production. So bowel disease, which is also going to be associated with hypomagnesemia, will lead to basically breakdown of your gut barrier, which will lead to too much absorption of that oxalate in your diet, which will lead to too much urinary oxalate. And that additionally, that malabsorption will not just the breakdown from the inflammation of the barrier, but also the production of having too many free fatty acids. Those free fatty acids will bind with calcium that's in your gut. When that calcium is no longer available to bind with the oxalate to allow it to pass out in your gut, as we showed before, that will lead to too much oxalate being available and much more being available in order to lead to a higher plasma oxalate and eventually to a hyperoxaluria. Similarly, with the patients with bariatric surgery, will almost inevitably end up getting too much calcium, too much oxalate being absorbed into their bloodstream and then eventually excreted into the urine. Basically, the reduction of the intestinal oxalobacter, which can digest this oxalate, will lead to increased absorption of oxalate. Again, you have these similar mechanisms that basically lead these patients to get calcium oxalate stones, and that being essentially inevitable. So what do we do? I'll quote Dr. Pennison, Dr. Best, who have lectured on this before, saying, telling people to completely stop taking their oxalate, that's a dietary fad online, but like these oxalate containing foods are really good for you. They're good for cardiovascular reasons, metabolic reasons, antioxidants, right? And we have other solutions. So, the argument would be not to do a low oxalate diet, which leads to all these other things that can actually promote calcium oxalate stones, and rather instead, to just increase your calcium intake at the same time, which would bind with the oxalate and prevent absorption. And so we can treat these patients empirically with potassium citrate, or we can give vitamin B6 to help that endogenous breakdown of oxalate, or give them calcium citrate, which is essentially Tums, to take at the same time that they're having a large oxalate meal to prevent that oxalate absorption, or magnesium oxide to help replenish some of that hypomagnesuria. So let's talk about potassium citrate for a second. So we talked about you're going to have to monitor the potassium for patients who are, especially with renal disease. You want to follow your 24-hour urines to see if you're giving the right dose. I have patients take it with food to prevent some of the GI side effects. And usually in these patients, if they're able to overcome the initial couple days of GI side effects and it's not really too bad, they'll then be good for a long term. I rarely have a patient, multiple years down the line hearing of them develop GI side effects. Again, seeing the capsule in the stool is okay. And if they have short gut or absorption issues, give them the liquid form. You can either do BID or TID dosing. But again, realize we are really asking a lot from these patients. So let's talk about the other reason you can form calcium stones. And that is having too much calcium in your urine. It's intuitive. You have too much calcium, you form calcium stones. And so for patients with hypercalciuria, there can be many causes, but that doesn't really always matter in terms of treatment. This used to be something that we really talked about as much as the three types of causes, the absorptive, renal leak, or resorptive. But at the end of the day, except for resorptive, if you have hyperparathyroidism, if it's absorptive or renal leak, you're going to treat them basically the same way. So let's quickly talk, hyperparathyroidism. This is, pretty obvious why that would cause. But if let's say you have absorptive, let's say you have too much calcium in the body that you're taking in too much. Maybe I've had a patient before who was basically overdosing on Tums, and sure enough formed calcium oxalate stones. And when she stopped the Tums overdosing and treated her GERD with a PPI instead, she stopped forming stones. You could be overdosing on milk or vitamin D, basically some of these alternative fads. And there was a study previously showing that a massively high dietary calcium intake led to having the risk of higher symptomatic risk of kidney stones. So the question then becomes, okay, great, we should have a low calcium diet, and it turns out that doesn't work either. A little bit after that, they tried randomizing patients to a low calcium diet as opposed to a normal calcium with low protein and low salt. And this study, which is over 20 years old, really forms the foundation of our dietary guidance. So if there are all these online dietary fads to prevent kidney stones, but if you just have patients do a low protein, low animal protein specifically, low salt diet with normal calcium intake, that's the best diet that they can do. So renal leak, how does this occur? Well, this is actually essentially ends up being one that you sometimes just have too much salt that drives the calcium leak. So one of the key things is that you need to limit a patient's salt intake. But this hypercalcuria could also be that you're not really reabsorbing enough calcium, whether that be in your proximal or distal tubule. And so that's actually where thiazides come in, right? Chlorthalidone, which again, you need to limit salt intake, functions by preventing some of that calcium reabsorption. The problem is that this thiazide will tend to have side effects. Specifically, it will cause a hypocalcemia and a hypocitraturia. And so therefore, if I'm putting a patient on a thiazide, I personally always supplement them with potassium citrate to combat that. A natural way of doing this will show up on your in-service, is with fish oil, which decreases calcium and oxalate excretion via a progesterone mechanism. That's almost like a natural way, or a more natural way, I should say, of preventing this hypercalciuria. There was a recent study published. This is an interesting study. This was where they published patients randomized to thiazide. I think the goal of the study was essentially to see the best dose, whether you could avoid using a high dose of hydrochlorothiazide, which tends to have more side effects. But essentially, the study was run without citrate supplementation, and it showed really no effect in terms of thiazides working. So, we're limited a little bit because they didn't give the citrate supplementation, and as I said before, that leads to a hyposituria, but it does suggest that thiazides are probably not as effective as we once thought. And obviously this is something that's going to need to be looked into a little more. So hyperparathyroidism, if you have a massive amount of PTH, that will cause you to have way too much calcium in your urine. The thing to always realize when you check a PTH on these patients, and anyone with hypercalciuria, you certainly should, is that it might be appropriate elevated if they're vitamin D deficient. So if the patient has like normal calcium in their blood, it might be that they're just vitamin D deficient. You supplement the vitamin D, and sometimes the PTH comes back to normal. Otherwise, you can do a CT of the NACA parathyroid protocol, and many of these patients actually do require parathyroidectomy. This is uncommon, but it's not unheard of. I've certainly seen a few patients with it myself. And you'll refer them to your endocrine surgeon or surgical oncologist, and they can actually cure them eventually of their kidney stones. So patients with calcium phosphate stones, these are hard to treat because these form at a higher pH, and when you give them potassium citrate, this raises their pH. What you'll actually see is this often happens in patients with hyperparathyroidism. So you check a PTH on everyone. I check it on everyone, at least any patient with hypercalcemia and hypercalcuria you should be checking on. And you do the best that you can. You treat them with potassium citrate, thiazide, an anti-hypercalciuria diet, meaning we talked about before, of low sodium diet, low animal protein. These are very tough to treat, as you will find. And that's basically was a summary of all of calcium stones. So believe it or not, all of that was just calcium stones. And I do think it's important to think of them separately because it really helps compartmentalize and understand the difference in treatments, right? The only treatments that we really discussed there were potassium citrate and thiazides, as well as some dietary changes. And now you'll see we're going to go into some of these more esoteric stones, which they love to show up on the in-service, but actually are pretty rare in real life, with maybe the exception of uric acid stones. So uric acid stones, obviously our pH scale, they show up closer to the 5s than they do our normal, closer to 7 or 6.8 of urine. And there's this great graph which shows that's worth dwelling on just because it shows just how drastic the changes are. If you see here, this is the amount of uric acid that you have in your body, and you can see it does have an effect. It's not like these numbers are not much higher. But if you look at urinary pH, look at the drastic difference between a patient with closer to 7 and the effect that having more uric acid has, and the effects of once you just get down to this 5.5, the massive amount of undissociated uric acid that's going to form these uric acid stones that you have. All that matters really for patients with uric acid stones is pH. If you can appropriately treat the pH, you will prevent uric acid stones. You'll bring them further down this part of the scale where they're not going to form any stones. And so all you have to do is alkalinize the urine. It's either potassium citrate or sodium bicarb. There's a classic question that'll show up on your in-service, which is that you can get over alkalinize, you get to 8, and that's when you form those calcium phosphate stones that we were talking about. The answer is, you recheck a 24-hour urine or a UA, or you reanalyze the stone to see why they're forming, and it turns out to be a calcium phosphate stone. One thing that's worth mentioning, patients with uric acid stones consistently, and I've seen this in the community, patients who are referred to me, for some reason, despite all the things that we just discussed about for the past 25 minutes or so, are still offered allopurinol by patients who are like, oh, uric acid stones, that's allopurinol. That's not true. For patients with uric acid stones, and again, that's why we start with the stone, the patients with uric acid stones, the thing that we have to think about and the thing that we have to deal with is the pH. There is an effect of having too much uric acid, but if you are appropriately treating the pH, allopurinols, you don't even need it. It's worth noting that a lot of these patients who are forming uric acid stones, just giving a plug for some of my own research, they will consistently have a higher risk of having metabolic syndrome. If you have a patient who comes in this way, as they have more and more metabolic syndrome components, you're going to see their risk of uric acid stones go up. Still, the most likely stone for them to form is going to be that calcium oxalate stone, but your risk of uric acid stone is higher, and these are the patients who you should make sure, wait, do you have a cardiologist? Do you have a primary care physician? Because intervening now, this is sometimes their first touch with a medical care, and they're in an extreme amount of pain. Now they're going to be much more willing to have the metabolic syndrome being treated, and especially as we've been seeing with some of these newer drugs, you can literally add decades to their life by intervening early. And so one thing that you're seeing is in the proximal tubule, you're seeing the effects of insulin resistance. So normally with insulin stimulation, you basically have the breakdown of glutamine into ammonia, which will bind in your nephron. You're going to see that bind with some of this acid and pass safely out of the body without causing too much of an acidic environment, which uric acid stone will form. But with insulin resistance, that's not happening as much. And so when you're not having this NH3 being excreted out into the lumen, you're not having that binding. You're going to have much more hydrogen ions, or a much more acidic urine, and that's what leads to this increase in this uric acid. Unfortunately, we haven't found that yet treating this diabetes necessarily reverses it. Patients being on these diabetic medications don't tend to reverse this. It's maybe that some of this damage is already done, and that insulin resistance already somewhat exists. So why does hyperuricosuria matter in these patients? Why would giving them a diet, again with this big caveat that this is not your first line, matter? Well, for patients who have increased animal protein, they're going to have a higher acid content, and that decreased citrate availability overall still lowers the pH. So you still put these patients on that low animal protein diet, but it's still not, again, it's still not, I don't want to confuse this, you still want to be treating this patient's pH first. Again, you're going to see this effect of total uric acid, but it's not as important as the urinary pH. Xanthine stones, this will occasionally show up. They're extremely rare. You have a defect or inhibition of xanthine oxidase. There's no real medical treatment. If you have these patients who are on allopurinol that you've been basically inhibiting, then you're going to have a lot more xanthine. So you can stop the allopurinol. Really, you need to limit your animal protein. That's the precursor to all of these, and massively hydrate these patients. We're very limited in what we can do to treat them. Cystine stones, one of the favorite in-service topics. So it's an autosomal recessive that's on the in-service, defect in gene for proximal tubular reabsorption, that's also on the in-service. It's the cola amino acids, but the only one of those amino acids that actually forms a stone is cysteine, and that's because of the pH of solubility that it's at. I have seen these actual genes, the SLC3A1 gene or SLC7A9 gene, show up. The cysteine plugs the ducts of Bellini that showed up on the in-service. But I will put it this way: if the question is talking about a proximal tubule autosomal recessive defect in a gene, it's probably talking about cysteine. You probably don't need to memorize that SLC exactly, but it may show up that way. You can basically infer that that's what the question is asking about. So cystinuria is actually extremely difficult in real life to treat, although the answer is very simple on the in-service. These are patients who the recommendation is to tell them to drink, get 4 liters of urine output daily. That's basically impossible to do long term. That's essentially saying you need to wake up at night to drink. They're constantly urinating. It's extremely frustrating for these patients. You want to decrease their sodium intake, and you want to alkalinize their urine. We do this as our first line with potassium citrate. That's because the medications that we give can have pretty awful side effects, although they will show up very often on your in-service. Those are Thiola, which is alpha mercaptopropional glycine, or D-penicillamine with B6, which both of them can break up the disulfide bonds that the cysteine, that the two cysteines form the cysteine with. These are poorly tolerated. They have GI side effects, a rash. It's worth noting surgically when you're treating these patients, these are not really the patients that you would want to, let's say, do a just kind of a dust and hope that everything passes. These are patients you would want to clear. You'd want to have really good irrigation, whether that means that these are patients who are, if you're stuck between them, you'd be more likely to do a mini PCNL over a ureteroscopy for, or that you would want to have one of the newer suction devices or vacuum or very good irrigation, let's say with an access sheath. You do want to make sure that you're really clearing these patients because the chance of recurrence is so high. Struvite or infectious stones. Unfortunately, we see in an incredibly sad situations because they can be so deadly. These are made of magnesium ammonium phosphate. You want to completely clear these surgically. There used to be something called lithostat on the market that I believe has been pulled. That also can have some pretty terrible side effects that can prevent their growth but doesn't actually clear them. To prevent recurrence, you need to manage infections. And these patients who are often going to be your patients with, say, like spina bifida, cerebral palsy, patients with indwelling Foley catheters is very difficult. They're obviously colonized. Sometimes people put them on daily nitrofurantoin prophylaxis or single strength Bactrim. These patients have bacteria usually that have urease. Things like Pseudomonas, Proteus is really the one I see most common is Proteus, with Klebsiella or Staph aureus. They turn that urea into ammonia, which is going to raise that pH and cause these to I actually rarely see like purely struvite stones. I feel like they often will have calcium components, and so you can partially target that calcium in the dietary that we discussed before. But these are very tough patients to manage. You really do want to fully clear these surgically and with very good irrigation. And just leaving metabolic stones for a second, right? These are patients who are high risk for sepsis. You want to be pre-treating them with antibiotics ahead of time and really be prepared for potential sepsis. So lithostat or acetohydraxaminic acid is for any remaining quote unquote untreatable fragments. They can cause hemolytic anemia or DVTs. I've really actually never really seen it used very much anymore because of these side effects. Ammonium acid urate will show up. I've only ever seen it on an in-service. I've never seen it in real life. It can show up. It'll show up on your in-services. Patients with laxative abuse or malnutrition. You'll have a patient who's an immigrant, recent immigrant who has been malnourished. It'll be usually pretty obvious the way they write it. Very uncommon in the United States. So just leaving the in-service for a second, my personal real-world approach, I'm not saying this is the best way to do it. This is how I do, and I'm constantly learning and tweaking. I'll always get an initial BMP, which includes calcium, a hemoglobin A1C to screen for a metabolic disorder, PTH, and a uric acid. I'll get a 24-hour urine, and most importantly, I'll get the stone analysis. Putting those all together will usually give a pretty big, it's a pretty big, clear why these patients are forming stones. It's sometimes difficult to treat patients with certain types of stones, but it's usually not too hard to realize why they're forming the stone. If I'm initiating potassium citrate, I'll check up BMP at 2 weeks. I'll check at 3 months a 24-hour urine to make sure they're on the right dose, whether I need to sometimes double it or 1.5 it. And what I would say is that stone recurrence is the ultimate arbiter of adjustments, right? It's really important, I think, to not be treating the numbers on the 24-hour urine, but to be treating the patient. So if they're not having any recurrence of stones on a certain dosage, even if their numbers aren't perfect, I won't adjust it. I won't risk side effects. Again, we talked about how hard compliance is for these patients. So if they're happy and that patient is doing well and not recurring on the dosage that they're on, I leave them where they are. Thank you for listening. Good luck on your in-service. I'd also like to thank the many mentors and lecturers on metabolic stone disease, which has informed my own practice and my own understanding of metabolic stone treatments, and from whom most of this lecture knowledge base has stemmed. I'd also encourage you, if you have any questions, to please reach out to me, as well as if you're interested in endourology and stones in general, or interested in the endourology fellowship that we have at Westchester. We'd certainly love to hear from anyone interested for that. Good luck on your in-service. Good luck on your boards. I'm sure you'll do great, and I hope this was useful in your understanding of metabolic stone disease.